Hello, and welcome to today's webinar. I'm Eddie Lang. I'm an emergency doc in Calgary, and on behalf of CAPE, the Canadian Association of Emergency Physicians, I am delighted to be your moderator for what I know will be a great session. Let me tell you a little bit about the Scientific Planning Committee for this and other sessions. It consists of Stacy Kitts, Kira Gruwal, Rob Stenstrom, and myself. We can show disclosures at this point to let you know a little bit about us. But we've been working from information from the needs assessment planning survey and have just selected our topics that way. I just want to also let you know that we did receive financial support from BMS Pfizer in the form of an educational grant. And if we can proceed to the mitigating potential bias slide, we can show you that we've also gone out of our way to make sure that those are minimized. So first, let me tell you a little bit more about this topic. Again, through the needs assessment survey, we found that emergency physicians still have lots of questions about bleeding management as we evolve out of the heparin and warfarin era to DOACs. Not only were there questions about the use of specific reversal agents, but also we encountered a lot of questions and concerns about the timing of restarting anticoagulants in the setting of nuisance bleeding, as well as critical management issues in terms of the timing of endoscopy and how to leverage the lab in terms of determining when in fact a bleeding incident is in fact being driven by a DOAC. Also lots of questions about how to time surgical interventions and things that we do in the emergency department, like lumbar punctures and central lines in a patient who's actively taking. I also want to remind everybody that we're trying to make this as interactive as possible. So we encourage you to use the chat feature, and that we will want you to put as many questions as you want into the chat function so we can get those addressed by our two speakers. We will also be using the Mentimeter website and interface to collect some polling questions from you in the audience. So we're going to bring that up now. You can either use your phone to scan the QR code or else go to enter that code on the menti.com website. And why don't we just get going to see if we can get you all onto Menti and answer a key question to let us know a little bit more about you and the audience. So if we can bring up that first polling question, and maybe while that's happening, let me tell you a little bit about our two speakers. I'm very pleased that we're joined tonight by Dr. Deepa Suryanarayan, who's a clinical assistant professor in the Department of Medicine and Hematology here in Calgary. We've gotten to work together on a number of projects. We're both members of Thrombosis Canada. And Deepa, we're very excited to have with us, she's done her master's in research methodology from McMaster and is a thrombosis fellow and graduate of that program. And I'd like to also introduce and welcome Rob. Rob, thank you for wearing a tie tonight in a pandemic. That's really sweet. But let's just now see. Thank you for the feedback on the Mentimeter. It looks like we have a good mix of folks out there, mostly urban, but a good mix, a good share of urban community and rural community physicians as well. So that's fantastic. So last order of business then, before we move on to our presentation, is to tell you a little bit more about Dr. Rob Stenstrom, who's an emergency physician at St. Paul's, clinical assistant professor at the University of British Columbia, well known to CAPE, has been on the speaker circuit and presenting on a number of topics over the years. Particular interests are in therapeutic hypothermia, cardiac arrest, and sepsis. And has done a lot of great work in that area. What you may not know about Rob is that he's also very much involved in developing world health and does a number of board member work for charity organizations that deliver healthcare outreach in countries like Nicaragua, Peru, Nepal, and Zambia. So super excited to have Deepa and Rob with us tonight. We're going to talk to you about bleeding management in the DOAC era, and I will let them take it away. Thank you.
Thanks for the introduction, Eddie. And really, it's an honor to present this topic along with Dr. Stenstrom. As a hematologist and a thrombosis physician, this is a topic that we deal with on a regular basis, along as you guys, our ER colleagues. And often we all know that these cases can be challenging to manage. So to begin the topic, it's good to understand where the targets of anticoagulation are. And so we all understand anticoagulation is a mainstay of treatment for the thromboembolic disorders. And this is mainly due to their tremendous therapeutic advantage in reducing overall mortality and morbidity in these patients. The options have certainly expanded over the past decade with the introduction of the direct oral anticoagulant agents. Before we embark on the management of bleeding complications, it's always helpful to understand and review the mechanism of action of these agents, because this will provide a better understanding for our approaches when we're thinking about reversing the anticoagulant effects of these agents. So this is the simpler version of a coagulation cascade. Of course, we remember the complicated version that kept us all awake as med student and gave us all nightmares. So, but that is my life's work at this point, and that's what I do for a living. So to briefly recapitulate, the formulation of a thrombus is a final step in the cascading series of enzymatic reactions that may be initiated either by a trauma or by an endothelial cell disruption. So interaction with the tissue factor and the factor 7 would subsequently lead to activation of the final step of your cascade, which is basically converting your factor to activated factor 10A and further promoting prothrombin to thrombin and then fibrinogen to fibrin and the formation of the final clot. So this dependence of a domino effect of these coagulation factors offers several targets for therapeutic intervention. So if we were to go back and talk about vitamin K antagonist, right? And these are targets the vitamin K dependent factors, which is your factor 2, factor 7, factor 9, and factor 10. And that's inhibited by your warfarin. And that's where you target, they exert their major anticoagulant effect. Then when it comes to low molecular weight heparins like fondaparinux and low molecular weight heparin, as you can see, they mainly target the factor 10A through the antithrombin. And the unfractionated heparin also targets the factor 2A. And because based on their half-lives, and that's the reason why unfractionated heparin has to be given IV monitored by your APTT, whereas the low molecular weight heparin and the fondaparinux could be given as once a day or twice a day injections. Now, the introduction of the DOACs, as you know, there have been two big classes of them, which is the direct thrombin inhibitor in the form of dabigatran, which, as you can see, targets the final stepway here, the conversion of prothrombin to the thrombin. And then the factor 10A inhibitors, which are the major 4 of them, which mainly target the factor 10A inhibitors. So moving on, next slide. So this study basically looked at the Canadian prescription volumes for all anticoagulants, including warfarin and DOACs, between January 2008 and 2014. And as you can see from this graph, the oral anticoagulant prescription generally has steadily increased annually since 2008. With availability, of course, of the DOACs, the proportion of the total of the oral anticoagulant prescription has steadily mainly seen an increase in the DOACs, but certainly the VKA still remains, but as the use of VKA and the prescription of VKA has gradually showing a lower trend. The trend is likely to continue as we give more preference to the DOACs over VKA, given expanding indications, as well as growing physician expertise and experience, and of course, the published guidelines supporting their use as well. And we can move on to the next slide. Okay. And this indicates that the warfarin is definitely, the use has decreased over the years, but it is not completely gone. So we need to still be aware and be comfortable with managing the bleeding complications on warfarin, because there are many scenarios still where the warfarin is a mainstay of treatment and preferred over a direct oral anticoagulant agent, such as in mechanical heart valves, in antiphospholipid antibodies, and renal failures. And if anybody is at a high risk for GI bleeding, if there is a strong drug interactions with the DOACs. And more important of all, being in a socialized medicine, if they have inadequate coverage for the DOACs, and cost is a restraining factor, they would still be candidates mainly for warfarin. Hence, it's very imperative as physicians that we get comfortable and to manage the patients who still present with these bleeding complications on these agents. So for the next slide. So why are the DOACs the most preferred? And we all know this data very well. And as the ER physicians, you are well aware of the safety data that is favoring the DOACs. It's mainly seen with the significant reduction in intracranial bleeding that has favored their use over warfarin. Okay, next slide, Rob. But however, there's a disclaimer on all oral anticoagulants. All oral anticoagulants are at risk, do cause bleeding. So it's not it's not an unknown thing, and that's a very well-known side effect of an oral anticoagulant therapy. When you look at overall annual incidence risk of bleeding with an oral warfarin, it is still around 2 to 5% for major bleeding, and driven around 0.5 to 1% for fatal bleeding, and around 0.2 to 0.4% for intracranial bleeding. When you compare that to the direct oral anticoagulant agent, and based on all the large randomized clinical trial and the observational data, the annual incidence is still around 3 to 4% risk for major bleeding, and driven mainly by the GI, around 50%, and 13% of the major bleeding being intracranial. So that's where I think, we need to still be aware that these are known complications, and this emphasizes that we need to know how to manage these bleeding complications when they present to the emergency department. Next one. And they still do. So there are a lot of still patients presenting with the bleeding complications or due to adverse drug events. And this is just one of the studies that looked specifically in older US adults and looking for emergency hospitalizations for adverse drug event. And as you can see from the graph, warfarin still constituted a significant proportion of those. The next slide. Why should they even matter, right? Because we do know that the case fatality rates for major bleeding remain significantly high for these agents. With warfarin, it is around 13.4% and 9.1% for those who receive it received it for greater than 3 months at a time. In comparison to that, the case fatality rates for DOACs was around 7.57% versus 11.04%. And all of these, what happens is they do cause interruption and discontinuation of anticoagulation therapy, which itself comes with further challenges that they are at a higher risk for recurrent VTE as well as stroke during that period of anticoagulation therapy. And this can increase up to 22-fold in intracranial bleeding patients, whereas up to 13% increased risk of recurrent VTE in the patients who are presenting with a non-ICH, and mainly attributed to the discontinuation of anticoagulation therapy. So as you can see, this is a very fine line that we need to kind of balance when we are treating these patients with the anticoagulation, where of course you want to reduce their VTE and the stroke risk, but we also need to balance that with the bleeding risk. So sometimes in some patients, this can be really, really challenging. Next slide, please. So whenever you're faced with the major bleed on these patients, the key things to know are, after we have kind of screamed into our own head, oh my God, what am I going to do? Is that how do we go in a systematic manner of assessing how we constitute our management plan for these patients? So first thing always is establish your indication for anticoagulant therapy. Are they on for atrial fibrillation? Are they on for a VTE indications? And do they need to be on that, after this event? Again, type and severity is important to establish from the get-go. Is this a major bleeding that you're dealing with, or is this a nuisance bleeding that they're presenting with? What is the type of oral anticoagulant they are on, and what is the timing of their last dose? Of course, always ensure supportive measures are already initiated even prior to, thinking about whether we need to send for lab work, are we going to be ordering any antidotes at this point or any reversal agents. You need to make sure what is the established renal function at this point, because this will become important when you're dealing with your direct oral anticoagulant agent, depending on their half-life and clearance. What about, is there any evidence or any lab work that we can do to establish or suggest the presence of these in a significant quantity? And we'll talk about all these aspects as we go through the presentation. And then, of course, how do we establish and that we do need to use a reversal agent, and what is that availability in your center, and how do you tailor that into your management plan with this patient? Next slide. So when do you need to consider reversal? Do all of the bleeds need reversal? As ER physicians, you guys are well versed with this than me. But certainly we all agree that bleeding into a critical site, like intracranial bleeding or CNS bleeding or any retroperitoneal or intra-articular, intramuscular bleeding does constitute a major bleeding. If the patient is hemodynamically unstable because of the bleeding, certainly you may need to consider reversal. And also, even if it is a non-intracranial bleeding, but it's ongoing bleeding despite you doing everything that you can, instituting all the supportive measures, maybe it's time to consider for a reversal agent. Of course, the other things that come into play, very rarely drug overdoses, which we still do see even with anticoagulant agent, and the renal dysfunction. In fact, I had one patient with the rivaroxaban overdosages that we needed to deal with the bleeding reversal. So these are challenges. And again, these are very well versed, and you guys see these scenarios more than a hematologist does. So next slide. And then again, the non-major bleeds, we are not going to spend too much time about it, but we do know that patients present with a lot of epistaxis, menorrhagia, and hematuриas in these patients, and these are not uncommon even on a direct oral anticoagulant agent compared to warfarin. So we have to make decisions whether you're going to hold your oral anticoagulant therapy for that, and what are the local supportive measures that you're going to give. And again, always assess, are they on any additional reversible risk factors like antiplatelet therapies? Are they on any NSAIDs? So because these would be important for you to hold if you're going to deal with a non-major bleeding. Always review indication. Do they still need to be on the medication? What about the dose, the frequency, and also depends upon how good the organ functions are. So this chart just would walk you through it, and these, I'm happy to provide that and have more discussions on that particular chart if need be, but we will quickly move on to the cases.
Thank you, Deepa. Thank you very much. So these are my disclosures. And Eddie, thanks for the compliment on the tie. I knew if I hung on to this new wave 1980s tie long enough, it would come back into style. So here it is. So we'll go on to, these are all, I'll let you know up front, these are all sort of real cases that either myself or colleagues have seen. So yeah, so first one is an older one from about 7 or 8 years ago, but it's a 78-year-old male who's Cantonese speaking. The daughter is at the bedside, so she can translate for you, which isn't always the case, as we know. Past medical history of atrial fibrillation, hypertension, old TB. Daughter informs us that she is in fact full code, or he is in fact full code. And he's on warfarin, and an INR from couple of weeks ago was 2.8, so it's therapeutic. And he's also on metoprolol and hydrochlorothiazide. The HPI is that he's been feeling unwell for 4 days. He's had a non-productive cough and subjective fever, although it hasn't been measured. He has been coughing up small amounts of blood initially, sort of on the Kleenex when he coughs, but this has increased significantly in the last couple of hours, and that's what brought them into hospital. At the bedside, he looks unwell. He's in moderate to severe respiratory distress, not particularly tachycardic, but he is on a beta blocker, but he is tachypnic. His SATs are 87% on non-rebreather, and he's afebrile. So basically, you have in front of you a fairly sick patient who you're worried about and you're going to get on right away. I'm going to ask a question here. There's two potential answers. And the question is how dependable is an INR measurement from 2 weeks previously. So it's sort of tossing a coin here. It's what got me through medical school. So it's either dependable, so it's going to be similar, or it's going to be not dependable. So I'll just give you a few seconds to answer on that. And these questions aren't made to challenge you so much as to just sort of bring out the fact that that INRs are, as we know, incredibly labile, and anything, you sneeze and your INR can go up or down, or eat the wrong thing, or take an antibiotic, or there's so many things that can influence it. And that's part of the reason why the push has been to switch to DOACs, because there's not this same lability, and you don't have to measure INRs. See, most people chose the second, that it's not dependable, certainly over a couple of weeks. Now that might not be the case if it's a couple of days. That's probably a little more reliable. And the other issue is with a patient who's this sick, you're not going to sit there and wait for an IR to come back, because we're not treating the number, we're treating the fact that this is a sort of pre-arrest patient. So that's the primary concern. And how much is this INR of 4.4? Well, it could be 1.4, it could be 10, it could be unmeasurable because it's so high. The treatment's going to be the same. If they're on an anticoagulant, you're going to do whatever you can to deal with that and treat that. So really, the INR issue is I think a minor one in this case. It will be more important when you're looking at those bleeds that are not life-threatening. So to start the resuscitation, of course, you have your IVs, you have normal saline running. He's in quite severe respiratory distress and can't maintain that respiratory rate of 42 per minute. So he's intubated with etomidate and succinylcholine. And remember, this is a few years back, so probably nowadays you might opt for rocuronium, which would be reasonable. So his hemoglobin is 75 and the INR is 4.4. So again, not the treatment is not going to really depend so much on the INR. So what to do about this? As I said, not a big issue in this case. We're not going to treat the number. So I think what we're going to do is give different things that we can to treat the warfarin that's on board. So Dr. Narayan, do you want to take this one?
The first thing that, of course, when it comes to warfarin, that one at our disposal, and the most common things that we tend to use for reversal is, of course, it's a vitamin K, inhibitor. So you're going to give them vitamin K. Right, and the dosages can vary. And also the route of administration can also vary. But most of the times, if it's a life-threatening major bleeding, you would prefer to give them IV, and you could give them 5 to 10 milligrams IV. And time of onset. Again, the question is, of course, IV. The reason you choose the IV is it has a faster onset than compared to the oral agent or the subcutaneous vitamin K. But in itself alone, it's quite too slow to act in patients if you're going to be thinking of major or life-threatening bleeding. But what you can certainly have that at a disposable, and if that's what you have at your center, you would definitely give them vitamin K. In fact, when some of the observational studies had looked at how well we manage the warfarin related bleeding in emergency department compared to the DOAC bleeds, in a lot of the institutions, I think that we did pretty poorly even with warfarin, even despite having vitamin K and all the other reversal agents. So something to bear in mind, that we still need to aggressively use the products and availability of the agents that we have at our disposal, and use it in a timely manner to achieve the clinical outcome. So the next slide, Rob. And also remember, and it's also important to understand when do we optimally use, what dose we optimally use when it comes to vitamin K. And it's important to understand that nuances. Sometimes if the patient, let's say this is in a non-life-threatening setting, they're just presenting with a nuisance, epistaxis, or anything that is deemed to be low-risk bleed, it is resolving spontaneously without needing any nasal packing, cauterization. Depending on the INR, you could consider doing different measures. Like if it is less than 5 and they're presenting with a low risk of bleeding, you could just withhold it. You don't have to give them vitamin K, and you could just wait for it to drift down and repeat it in 1 to 2 days. But always, or you could consider, reinitiating them at a reduced dose in 24 to 48 hours, or when the INR is within the therapeutic range. If it is between 5 to 9, you would do the same thing, but you can repeat your INR within 24 hours. Certainly, if it is greater than 9, our comfort level is a little bit lower in terms of letting it fly, So in that kind of cases, the recommendation, not go too big doses on vitamin K. The reason being is that as a thrombosis physician, I'm also worried about overly correcting their warfarin, because giving them high doses of vitamin K will definitely make the numbers look prettier, but it'll make it that much more challenging to reinitiate anticoagulation and get them up to the therapeutic range. You may need to bridge some of these patients, because if we have given them 10 milligrams of vitamin K from the get-go, and now we are having difficulty getting them up to the therapeutic range. So something, less is always a key when it comes to low risk bleeding situations. So in fact, I only say 1 to 2 milligrams orally you could give them, and then resume warfarin at a reduced dose whenever you're comfortable, or when the INR is within the therapeutic range, or even consider lowering your dose of warfarin overall. So next slide. Of course, if the high risk of bleeding, all bets are off, you are dealing with a fatal bleeding, life-threatening bleeding, definitely doesn't matter what your INR is. Just as Rob alluded, at this point of time, it's time for action, right? I mean, you would give everything that you can, and you could consider, 5 milligrams or 10 milligrams. You would give it as a stat within that, but always follow that up with a, repeat INR within 6 to 12 hours. And always, think about resuming that at a reduced dose when it is a therapeutic range. Certainly, if the bleeding risk is deemed to be very high, you continue to assess the need for, whether you still need to be on warfarin or possibly continue to hold it. Next slide. When the vitamin K is not enough, because we do know that, first of all, they take a long time for action, and they may not be sufficient enough for a complete reversal, especially if you're dealing with life-threatening bleeding. In that kind of cases, you do need factors, and there are multiple factor-containing products that we talk about, which are available to us in the emergency department based on your centers. But it's always important to understand what these factors and what the differences are there within those factors in itself. The common ones, of course, for the longest time, we were using fresh frozen plasma. And these contain all your vitamin K dependent factors. They also contain your fibrinogen, also factor 13, and plasma proteins and electrolytes. But the drawback of the plasma has been that it is, first of all, it needs large volume for infusion, and also needs thawing time, because you need to thaw them before you can administer to the patient. And many a times they're also at higher risk for developing transfusion related acute lung injuries, and also transfusion associated cardiac overload. And hence, there has been a shift towards, using less of the fresh frozen plasma. And then came the PCCs, which are your prothrombin complexes. And among that, there are differences, but we have at our disposal in Alberta mainly using 4-factor PCCs. And these contain your inactivated specific vitamin K dependent factors, along with protein CNS. And an important thing to be aware of is they also have heparin. So if you're dealing with a patient with a previous history of a HIT, you need to be aware, giving them, like PCC, you need to be cognizant about that, and possibly not the best option if the patient had a known allergy to heparin and demonstrably had a HIT. The factors that we tend to use is your activated protein complex concentrates, also known as FIBA, which stands for factor 8 inhibitor bypass activity. Actually, it used to be used a lot more in hemophiliacs, both of the PCC and the APCC, before they were used for warfarin reversal. And the important aspect of FIBA is that it has an specifically activated factor 7 with the inactivated rest of the factors. So many a times we tend to use them, and we'll talk about the use of it a bit more when we are talking specific about the agent reversals, especially with the direct oral anticoagulant agent. And then there is the recombinant factor 7A, the big guns that we bring in when nothing else is working, right? I mean, like give them a whole load of activated factor 7. The reason why this becomes important is, again, I'm trying to get you back to that nightmarish diagram that I showed you, right? You're trying to overwhelm that all the inhibition and finally get the final pathway of the clot formation to progress. So that's the whole point of, you know, trying to overcome this inhibition by any of these agents. Next slide. So for the longest time, we wondered whether fresh frozen plasma is better, the PCC is better. And this was a randomized controlled trial, which looked at and compared the four-factor PCC to plasma in those patients who needed vitamin K, the INR reversal when they were on warfarin for either procedures or bleeding concerns. And as you can see, the four-factor PCC certainly showed superiority and in INR correction in comparison to plasma, and this has led to the guidelines recommending actually PCC over fresh frozen plasma as the product of choice when you're considering warfarin reversal. The next slide. And this looked at basically using prothrombin complex concentrates in emergency patients who are presenting on warfarin associated either bleeding or needing emergency surgery and reversal. And also it basically looked at how good we are at initiating these products, right? And they looked at door to PCC time. As you can see, we can do much better than this, right? I mean, all patients had a delay of at least 5.2 hours. And specifically intracranial bleeding, interestingly, it was 3 hours before they got from door to the PCC. And so that's something we can work on. And in the emergency room, when these are presented, yes, as Rob already told you guys, like, yes, you can wait for all the testing to come back and, wait for those lab tests, but actually you need to start instituting these measures right away, especially in a situation with a life-threatening bleeding. And again, to reiterate what we have always been telling, the mortality rates with these continue to be high, right? And this was at least 7.6% during the acute bleeding freeze, at overall still a significantly high mortality of 25.2%. And again, the risk of VTE, which we already talked about, it's still quite high until day 60, that that they could be at a risk for recurrent VTE as well. Next slide. So for PCC for warfarin reversal. So in the setting of any acute major bleeding or need for urgent surgery or emergency reversal, let's say, they need to go for endoscopy, that you need to go and cauterize anything, or they need to go get a bronch, right? At that point of time, there are certain guidelines that you can use to give what dose that you would prefer. But most of us are comfortable with, usually they present with a higher INR. You're going to go with 1,000 or 2,000 units of PCC, but it can also be adjusted based on your weight of your patients. If they have a higher BMI, you may need a little bit higher, but there is still a maximum cap dose. The reason why there is a maximum cap dose is there is also risk for VTE or thromboembolism and arterial clots with these overuse of these products. As you can understand, you overwhelm the coagulation cascade, then you don't want to tip them over to the other side of from bleeding to the clotting. So that's something to always be mindful about. And the pre-CCs, as I already touched upon, should not be administered if your patient is HIT positive. So something that you need to be, again, consider, especially with any prior history of it. The next slide. So I'll pass it on to Rob.
Sure, the case resolution. He got 2 units of O-negative blood up front. He did get 1,000 units of 4-factor PCC and some vitamin K IV. He was transferred to the intensive care unit. Respirology came in, bronched him, and they embolized a couple of vessels in the right upper lobe that were the culprit vessels. He was biopsied as well, and he was actually negative for active TB. His hemoglobin stabilized at 86 with no further transfusions after the first 2 units. He was extubated day 4, and he was switched to ASA for AFib stroke prevention after that. I'm not sure, Eddie, are we going to pause for questions, or are there questions?
I haven't seen any in the chat window, but I mean, just in general, a question for Deepa: is there, other than the HIT consideration, is there a time when we need to worry about PCC versus APCC? Is there a price consideration? What approach should we take most of the time?
Right. I think we're going to talk a little bit more in the next few slides about that, Eddie, and specific about the price considerations. And is there any differences in that? I think you're right. Of course, when you compare to the fresh frozen plasma, these are going to be more expensive, right? And yeah, that would play into your decision of which one would you choose. Yeah, we'll be touching base on that. Yeah.
Perfect. Thanks.
So I'm just going to briefly go over these bleeding risk scores. And I think, most of us are aware of HAS-BLED. And part of the problem with HAS-BLED or any of these scores is they share a lot of the same components as your sort of risk factor for stroke in atrial fibrillation. So if you look at CHAD 65, it has a lot of overlap with HAS-BLED. So that's a bit of an issue. I mean, so HAS-BLED, I think, is from an emergency department perspective, is the one we're most familiar with. But there are these other ones that have been looked at and investigated and validated in atrial fibrillation. And there are also ones that they're slightly different for the assessment of bleeding risk in VTE. So you'd think, and again, there's going to be a lot of overlap in some of these things if you look at them. In age and renal failure are the big ones, previous bleeding. But just to let you know that there are, in fact, slightly different scores if you're putting someone on an anticoagulant for VTE as opposed to atrial fibrillation. So we'll move on to case number 2. This is a 90-year-old male. And I'll preface this by saying that we were one of the investigating sites for idiracizumab. It was an open label study of the reversal agent for dabigatran. And this is actually a patient that came in and became part of this study. And so I'll just give you that background. But he presents with left lower quadrant cramping for a number of hours, maybe a whole day. Pain, he's had a fever. He had 10 bowel movements of dark and then bright red blood per rectum. He does have a history of a left leg DVT. He's had diverticulosis diagnosed based on a colonoscopy back a couple of years before he came in. And he's got a past history, including diabetes, hypertension, and coronary artery disease. Last creatinine was 105 a couple of months ago. He's on these medications. And this patient, actually, again, it was a real case, was given a sample of dabigatran by the patient's family doctor. And this is problematic for us, and more as we become reliant on these PharmaNet, was what we call it in BC, but there are these provincial databases of prescription drugs. So on this person's PharmaNet, the dabigatran didn't show up. And again, if we were faced with a situation where this was the case and the wife wasn't there to explain to us, or if the patient couldn't explain, say if it was an intracranial hemorrhage, we wouldn't have known that he was actually on an anticoagulant. So again, he doesn't look great. He's mentating well. His pressure is a little soft, given he's got a history of hypertension. His heart rate's 125. He's borderline febrile. He's got obvious dark red blood per rectum. He's got a couple of intravenous lines placed by EHS. You've got a hemoglobin that's 82, and it was 135 a couple of months ago. Slightly elevated INR, slightly elevated PTT, slightly elevated lactate, and an elevated troponin and renal function. Deepa, do you want to do this one?
So the oral anticoagulant associated and GI bleeding, we talked a bit about, the proposed mechanisms because they're a bit different when you compare it to warfarin versus a direct oral anticoagulant agent. Because in warfarin, there are, it is said to be just because of the systemic anticoagulation effect. And of course, lability of their INR values would play into this as well. But when it comes to the DOACs, as you know, the concern has always been there is a slightly increased GI bleeding risk with these agents. And that's mainly attributed to whether it is just due to their topical anticoagulant effect when you're orally, consuming them, whether it is associated with some incomplete absorption or not. And that's been the case, especially with DABI. You do know that the side effect always has been dyspepsia, right? So certainly there could be a component of that influencing the direct topical anticoagulant effect. There are a couple of other mechanisms that they've talked about. DABI is that, there is an intraluminal activation of a prodrug because it is a prodrug and that gets activated within the gastric intestinal system, and whether that's the reason why there is an increased tendency for GI bleeding with especially with dabigatran. And that has been a postulated hypothesis of sorts, with the likely predilection for colorectal bleeding because it gets broken down in the upper part of the GI tract and then transits down, causing that increased risk of colorectal bleeding. In terms of factor 10A, you do realize that part of this metabolism of these drugs can occur through the PGP, that is the P group inhibitor, the Afflexa pump, as well as the CYP3A, and the PGP can have a significant effect within the GI mucosa, and this could also play a role in again exerting that topical anticoagulant effect and causing the inflammation of that endothelium, and maybe at a higher risk for bleeding. And the common sources of GI bleeding on OACs, and this kind of depicts where that has been the common sites. So most of the common sites have been with peptic ulcer disease of the stomach or duodenum for upper GI tract bleeding, and diverticular bleeding for a lower GI bleeding. And we do know that there could be other sites of bleeding, but those would be a bit more unusual and specifically associated with either liver dysfunction, the varices, or like a Mallory stare with excessive retching, etc., and cancer, and other intermittent like alcohol consumption or NSAIDs, etc. So in terms of, as we talk about it, and there are also guidelines out there in order to how to optimally manage these bleeding when you are faced with on a direct oral anticoagulant agent or a VK. There's a whole lot of resources available, and this is a Canadian developed resource by the Canadian thrombosis experts, and these are also available in a free app, and I'm pretty sure you guys are all very well familiar with this, which can provide you more ongoing guidance when you're faced with these clinical scenarios. So do you want to do this one, Rob? Or?
Yeah, sure,
Okay.
sure. I mean, so this is just, I guess, a reiteration of what we were talking about previously. It's like you're going to look at your bleeds, and there's many ways you can sort of dichotomize them, but probably what we do in the emergency department is basically look at them as non-life-threatening, your epistaxis, nuisance bleeds, things like that. And then the ones that are more serious, such as the life, limb, or organ-threatening bleeds, in which case you're going to be more aggressive, obviously, in your treatment. Reversal agents are available. We'll talk a little bit about those. They're not the be-all and end-all. The reversal agent for rivaroxaban and apixaban is not yet, and Nextep Alpha is not yet available in Canada. It has been available in the States for a couple of years, but we're going to do all these other things as well.
When it comes to practical consideration, especially in this particular case with the direct oral anticoagulant agent, as we talked about, we have to mentally walk through these steps, like, depending on when was the last dose taken, because that would indicate, whether they're already, because they have a shorter half-life, you may not need to consider a reversal agent. Is there an indication for reversal? And in this case, like with a GI bleed, there is, and its urgency. And what's the indication of anticoagulation? Again, primarily, what's the renal function? Because you can estimate their half-life based on the renal clearance. So this is just a graph to, in a table that outlines why, what's the differences in terms of the different direct oral anticoagulant agent based on their renal clearance. So you can see that DABI is significantly dependent on the kidneys for elimination, with up to 80% renal dependency. Then Riva around 33% renally cleared. Apixaban is the lowest with 25%, and EDOX varying between 35 to 39%. Now this also, you can see overall the half-life has varies between 6 to 12 to 15 hours. So what happens, because this will change based on your patient's creatinine clearance at the time of the clinical presentation with the bleed, and that can help you estimate how much of the medication is still hanging on in the system, or what could be the estimated clearance time, and how long would they be present based on the creatinine clearance. The next slide. So this is just to indicate, look, in this particular example that you saw, this patient does have moderate renal impairment, and specifically given that the dabigatran, which is the most renally dependent of the direct oral anticoagulant agent, they would be, the half-life would be prolonged. So it would be 17 to 20 hours. So if the patient has taken this dose, or if you didn't know that the patient has taken the dose, this is what your estimated likely time would be, that this is going to be in your system. And then you can institute whether you want to go for the reversal agent or not based on that knowledge. The next one. So this always comes up. Of course, is there any test that we can reliably do that can predict us, how much of the quantity of the medication that is still about in the system? Unfortunately, so routine blood investigations often are used, but really cannot assess many of these agents' effects. So when you're talking specifically for dabigatran, you could, if you look at it, the PT, which is your prothrombin time, has a variable effect. So it may not be that helpful in case of a dabigatran associated bleeding presentation. APTT, which is your activated partial thromboplastin time, certainly could be increased. And because APTT has low sensitivity for factor 10A inhibitors, but definitely more sensitive for dabigatran. And so all it can tell you, well, a normal APTT cannot completely still rule out DABI levels, but if it is significantly elevated, can help you confirm the persistent presence of dabigatran. So that might be helpful if that is what you have at your disposal, at least as an initial measure. What about the thrombin clotting time? This definitely is, again, not very widely available in all the centers, but certainly available in the bigger tertiary care centers. If it is increased, then certainly it can tell you that there is presence of DABI, but a normal thrombin time still does not exclude completely the absence of dabigatran, but sometimes may give you a comfort level that there's no significant clinically relevant levels of dabigatran. So you can use it if that's what, again, if those are the ones that you have at your disposal. Anti-factor 10A is not going to be helpful with your dabigatran because it is a direct thrombin inhibitor. And there are other specialized tests which are more sensitive, but such as the dilute thrombin time assays, the eccrine chrombogenic assays, and eccrine clotting time. Again, these are not available in all the centers, and most of them are available in research setting and in a tertiary care center. So they definitely could be used to accurately tell you quantified dabigatran levels as such, but they may not be available to you in a timely fashion for you to make those decisions for the patient you're seeing right there in the emergency department with a major bleed.
So this is just a basically a flow chart that we won't go over. It's a little too busy, but for what you're going to do when you're faced with a patient on dabigatran, but you don't have access to uricizumab. Now, I know in British Columbia, you know, depending on where you are, there's mixed sort of availability of idarucizumab, which is a reversal agent. So in the bigger centers, certainly you can get access to it. And at St. Paul's, it's controlled by blood bank and pharmacy sort of together. Either one can issue it. But if you're in a place where you don't have easy access to idarucizumab, then you would just go through these other steps that we sort of went over, and they're not that different from what you would do in the warfarin bleeding. Always a good idea, you know, there are many things to consider here. So get your local hematopathologist or hematologist involved to help guide you, and that's certainly what we do at St. Paul's.
Just a quick overview on the DOAC reversal agents. Again, as we do have approved Health Canada approval and availability of idarucizumab, which is your dabigatran antidote, and it's a humanized FAB fragment specifically binding to DABI. And this again has been, well established with clinical trials, and you can give them in a 2.5 milligram bolus. You can repeat it, and a quick onset of less than 5 minutes. Just be cognizant, they're also expensive. They cost around $3,500 per 5 grams of a dosage in comparison to, let's say, even like an FFP would have costed you around $1,600. But again, you know, this is what you have, and this is a specific antidote, and you have to use it when you need to use it, and it's available. In terms of other factor 10A inhibitor, unfortunately, Health Canada has not yet approved andexanet alpha, but it's available in the States for reversal of oral factor 10A inhibitors. Again, it's important to know there's differences in dosing when it comes to rivaroxaban and apixaban, if we ever get an approval for this, but it's a quite quick onset of less than 2 minutes. Again, expense is key to consider in a public healthcare system. Then there is a universal one, which will reverse everything under the sun, pretty much any anticoagulant, but that's still in phase 2, and I would like to know more about it, and we don't know the timeline on it yet so far. The next slide. What about the other ones? So with the DOACs, remember, we can also, for the factor 10A inhibitors, in the absence of andexanet alpha, what else could we use? So we can certainly use the octoplex, and you could give them as a max of 3,000 units or 50 units per kilogram, and again contraindicated in heparin-induced thrombocytopenia, and so that is still an option for you to consider. And then there is the PCC in itself, the beriplex. This is not available in all the centers, but in certain centers they have more than octoplex, they have beriplex, and again it's a similar kind of an indication, similar kind of a dosage as a PCC. Then there is the fiber, and this sometimes has been used in dabigatran prior to the availability of idarucizumab. Now we have idarucizumab, so we usually go to idarucizumab and not really reserve fiber in case you do need ongoing support in terms of it. And so this could also be used for apixaban, edoxaban, rivaroxaban, but PCC is the preferred choice for those prior to using fiber. The next slide. What are the other things you would still have? Again, it all depends upon your center, its availability of these products, but you could still use the frozen plasma, which still could be used at 10 to 15 mils per kilogram. Again, caution in patients at risk for volume overload. It, again, should not be used to reverse just abnormal lab parameters from DOAC. There is cryoprecipitate. We don't really recommend using them that much, and we don't usually use them, and we tell them not to be used to reverse any of these DOAC, unless, of course, if you have fibrinogen level less than 1, because cryo contains that. And again, in the setting of massive, like coagulopathy, there's fibrinogen concentrates. Again, we only consider in very, very specific clinical scenarios. And then tranexamic acid is a common one, and I definitely recommend that to be used because in some of these settings, but I have to be cognizant about the slightly increased prothrombotic risk, especially when you're giving it with the additional PCC and everything that you're throwing at them.
Rob, Deepa, we had a great question about the possibility of using topical TXA or aerosolized TXA for the hemoptysis case. Mm-hmm. Any thoughts on that? Would that be worth a go?
I think so. It definitely makes sense, therapeutic sense to use it as a topical. That should be instituted. I don't see a reason that it'll increase your prothrombotic risk.
Yeah, that's
Rather than
a
that,
great
that's a
idea.
great idea. Yeah.
I think we use it a lot. I use it
Mm-hmm.
all the time for epistaxis.
Yep.
Whether they're anticoagulated or not. I
Yep.
just some of the IV and soak a pledget, and it seems
Mm-hmm.
to work quite well.
Yep. No, I think so. Yeah, I would encourage using that for sure.
Awesome, thank you. Hey, we're just to let the audience know we're tons of material here, obviously, all very, very important. We're running a little bit behind time, so if we can shoot through to that third case, I think people would really appreciate
quickly.
it. Thank you.
I think we
Yeah,
can just do a
absolutely.
quick review.
So the resolution on this, I'll just say that they in sort of this sort of order, actually they got the iduricizumab first because they were a study patient, and that seemed to, I mean, we did a bunch of things, but that seemed to stop the bleeding. So in our N of 3 or 4 that we had in the trial, it worked really well. So this is our last case, 72-year-old female with a sudden onset headache, vomiting, and right hemiparesis. She has atrial fibrillation, for which she is taking apixaban and some other medications. She's hemiparetic and dysarthric. GCS is actually okay when you initially see her, and she does have an elevated blood pressure. The other notable thing here, she's in renal failure, which she's not been before. You don't know because there's no previous history, with a slightly elevated potassium. This is her ECG, which I'm not going to belabor, but it just has that sort of diffuse T-wave inversion we've all seen before. So Deepa, I'll let you just go over this.
Quickly go over this one, because what could help you if you're dealing with the factor 10A inhibitors, right? So prothrombin time certainly could help sometimes, because rivaroxaban and edoxaban can increase the PT. Interesting, because apixaban has a minimal effect, and they're all in the same class of agents, but they have a variable effect on it. So if it's prolonged PT, MPT, or INR, this might indicate that there is still some presence of these agents. But none of the other ones would be helpful. APTT really not so much, because they could be mildly elevated in Riva and edox, but really apixaban, it's not very helpful. Obviously, thrombin clotting time is not going to be helpful for this. The anti-factor 10A can be used accurately to quantify it, but you have to remember they have to be calibrated to the specific DOACs, and that is not always available. And also the problem with the factor 10A inhibitors is the time. Is it available in a timely fashion for you to help make those clinical decisions? It's always challenging for us to get a quick turnaround on an anti-10A level. And also we do have in Calgary, we have a DOAC specific assays, but again, the turnaround time is I have never personally found it helpful that it's available in a timely manner. So that's a challenge. Again, in terms of this specific patient, as you can understand, he definitely has a significant renal impairment. So his clearance of apixaban is going to be delayed, and there will be some, its half-life would be prolonged in this kind of a scenario.
This is a CT. It's sort of what you would expect given the clinical presentation. And I'll just ask you quickly, what is the prognosis for anticoagulant-associated intracerebral hemorrhage with rapid, either specific or non-specific reversal? So let's assume that there's fairly quick reversal available, whether it's a reversal agent or the non-specific things we've been talking about. That's sort of the breakdown. And I'll just say that, intracranial hemorrhage is, probably the most feared complication of any sort of anticoagulation. And like we talked about before, one of the reasons why there's been this push to switch over to DOACs as opposed to warfarin. And the issue is when patients do have an intracerebral hemorrhage, it carries with it a very high mortality and morbidity rate. So in fact, when you look at, this patient who was managed with 4-factor PCC, and if you look at the numbers, sort of in terms of their clotting and so on, if we had some of those available, but the numbers came down really rapidly, but the hematoma expanded despite the fact. So it's basically one of those situations where you open the floodgates and it's really hard to stop things, no matter how aggressively you reverse or do what you're going to do. So I guess the bottom line is if you're bleeding on an anticoagulant, if it's an ICH, the prognosis is actually not very good. That doesn't mean we shouldn't try and shouldn't do everything we can. Obviously, we're going to do that, but it still carries a very high mortality rate.
So obviously, of course, we all come down to this, the prevention is better than cure, right? I mean, we'd like to prevent these bleeds from presenting into the emergency department and take care of it even before that happens. And they need antidote and reversal. The next slide, Rob. So important to address modifiable bleeding risk. And again, it's very, for the sake of time, I'm just going to touch upon only a few important points. Make sure that, we are treating their high blood pressures. We are discontinuing any other concomitant medications like aspirin, NSAIDs, limiting alcohol, considering PPI, and keeping an eye on, especially those patients whom you're starting a DOAC or a DOAC on a moderate renal insufficiency patient. It's important to timely assess their renal function in a periodic fashion, maybe 3 months or 6 months, especially in elderly patients as well. The next slide.
So the take-home points is a few of them here that we should all be aware, and well, we all know because we see this in our practice, that warfarin is still out there, and it is associated with an increased risk of intracerebral hemorrhage versus DOACs. But there's still many people on warfarin for valvular atrial fibrillation, for other reasons, cost, et cetera, et cetera. Fresh frozen plasma and 4-factor PCC are the mainstays. 4-factor PCC is probably a better treatment if you can get it in a timely fashion. Vitamin K is also helpful, but it does take a while to act. Dabigatran is currently in Canada the only DOAC with a reversal agent. That's iduronizumab. And I suspect that within, I don't know, I thought it would be available by now, but this adnexet alpha, which reverses apixaban and edoxaban and rivaroxaban, will be available. It's been out in the States for a couple of years now.
So again, to reiterate everything that we have covered already, instituting timely supportive measures, hemostatic therapies is key. And again, always think about it as an add-on agent for the reversal agents. Really, it's still important that the supportive measures should be the first thing to do in any case of acute bleeding. So not all bleedings need reversal agents. Have institutional protocols in place. We certainly have some, SCM order sets that are available in Calgary that would help make those decisions and how do you order these products. Always address modifiable risk factors. Very, very important to understand, because these guys, we didn't touch upon it, but they are at higher risk for recurrent VTEs. So when do we timely reinitiate it is also going to be a clinical discussion that you need to have with that patient.
And that, I think, wraps us up.
Well, a huge thank you to Dr. Suryanarayan and Dr. Stenstrom. What a great talk. So much to know, so much information. Apologies for running a bit late, and try to get to some of your questions. If there are other burning questions, please send them our way and we'll try to get them answered. Really valuable tips for us to use going forward. Just remind everybody, this is accredited by the Canadian College of Family Physicians and the Royal College, so don't forget to complete your evaluation form to get your credits. And you'll get a certificate of attendance that CAPE will mail out to you. Remember, CAPE has a number of interesting webinars coming up, including one on how to evaluate suspected recurrent VTE in the emergency department in patients who are both on and off treatment as well. Very excited to have Dr. Ian Steele and Claire Atzema coming on soon later this spring to bring us up to date on the latest guidance from CAPE on the management of atrial fibrillation. Again, a big thank you to CAPE, everyone who came out for this session. Wishing you all safety, health, and well-being over the next, hopefully, final difficult weeks of this pandemic. And look forward to seeing you the next time. Thanks very much.
Thanks very much.
Thanks, Rob. Thanks, Eddie.